Welcome to the ACMG Knowledge Nugget on newborn screening for Krabbe disease. This activity is intended for educational purposes only. Neither I nor the Planning Committee have any disclosures. This session is approved for 0.25 CME. To obtain CMEs for this activity, you'll need to pass the quiz with a score of at least 80% and complete the evaluation. This session is a companion to the Krabbe Disease ACT Sheets, which are freely available at www.acmg.net/ACT. ACT sheets are intended to be immediate resources for providers who encounter positive newborn screening results. Please keep in mind that a newborn screening result is just the first step in the diagnostic process. Further testing and evaluations are needed to determine if the newborn has the disease, a true positive result, or is unaffected, a false positive result. The ACT sheets are intended to provide an overview of the diseases identified by newborn screening and clear next steps for the management of a positive newborn screening result. This session will cover background information on Krabbe disease, including clinical features and the underlying genetic cause, actions a primary care provider needs to take upon receiving a screen-positive test result for Krabbe disease, clinical considerations, and supplemental resources. Krabbe disease, also known as globoid cell leukodystrophy, is a lysosomal disease caused by pathogenic variants found in the GALC gene, which leads to a decrease in galactocerebrosidase enzyme activity. This decreased activity results in the accumulation of cytosine, which impairs the formation of myelin and leads to severe, life-limiting neurological symptoms. The presentation of Krabbe disease is clinically variable and ranges from a rapidly progressive infantile form to more slowly progressive later onset forms. The infantile form of Krabbe disease is the most common, and symptoms usually begin during the first year of life. Early symptoms include irritability, muscle weakness, feeding problems, and spasticity. Life expectancy for the infantile form of Krabbe disease is severely limited. Those with later onset Krabbe disease will have much slower progression of disease symptoms, with vision and walking difficulties being the most common initial symptoms. Krabbe disease is inherited in an autosomal recessive manner, meaning that only infants with a pathogenic variant in both of their GALC genes will be affected. Parents of an infant or child with Krabbe disease are carriers and are unaffected, but have a 25% or 1 in 4 recurrence risk with any future children they have together. At this time, not all states provide newborn screening for Krabbe disease. A good resource for checking a state's newborn screening panel is the newbornscreening.hrsa.gov website. In the states that do screen for Krabbe disease, testing is generally performed by examining levels of the galactocerebrosidase enzyme, which is decreased in individuals with Krabbe disease. Some programs also examine the levels of cytosine as a second-tier test to help improve screening, differentiate between forms of Krabbe disease, and rule out cases of pseudodeficiency. Pseudodeficiency, which is commonly seen in lysosomal disorders, means that an infant's galactocerebrosidase enzyme levels appear low upon testing, but this decreased activity does not cause disease. Follow-up testing will demonstrate normal cytosine levels. These infants do not have and will never develop Krabbe disease. Now that you have an understanding of what Krabbe disease is, Let's talk about what to do if you have a patient screened positive for Krabbe disease during newborn screening. You will need to take the following actions. First, contact the family and do the following. Inform them of the newborn screening result and that more testing is needed to determine if their child does or does not have the disease. Ascertain clinical status. No clinical signs are expected in the neonatal period. Provide the family with basic information about Krabbe disease. Second, take a family history. Because Krabbe disease is inherited in an autosomal recessive manner, it is common for there to be no known family history of Krabbe disease. Third, arrange an immediate referral to a Krabbe disease specialist for genetic counseling, a comprehensive clinical evaluation, and discussion of treatment options. The specialist could be a pediatric geneticist, neurologist, or transplant specialist. The clinical evaluations should include a comprehensive physical assessment by an experienced Krabbe disease specialist. Fourth, working with the appropriate specialist, take steps to ensure biochemical and/or molecular confirmation of the newborn screening result. Confirmatory testing includes galactocerebrosidase enzyme analysis, psychosine analysis, and GALC gene sequencing. Fifth, report the final diagnostic outcome back to your state newborn screening program. The only available treatment option for Krabbe disease is hematopoietic stem cell transplantation. This treatment is most effective if done before 30 days of life in the infantile form and prior to the onset of clinical symptoms in the later onset forms. Gene therapy clinical trials may also be available. As you continue to care for your patient with a positive newborn screen for Krabbe disease, it is likely additional questions and concerns will come up. Here are some resources where you can obtain information on Krabbe disease, appropriate laboratories and tests, and genetic specialists. Before we end today's session, let's have a quick review. First, Krabbe disease is a serious condition, and identification of affected individuals is essential for administration of early treatment. Second, newborn screening may identify both the infantile and later onset forms of Krabbe disease. Third, ACT sheets are freely available on the ACMG website to review in the event of a screen positive result. In addition to Krabbe disease, ACT sheets are available for many other diseases that can be identified through newborn screening.